Again, my practice has been whoever's walked through the door, but in those who've been referred with fibromyalgia, I've managed to demonstrate that in fact they have a series of different issues. How do I know that? They're implanted, they've got several sets of leads in. They're all medication and pain-free. So it raises a question about that diagnosis.
Hello, this is Dr. Karmy for Chronic Pain Chronicles, and today with us we have Dr. Cornish. He is a pain physician from Australia, and he's developed a very innovative approach to managing chronic pain. Hello, Dr. Cornish.
Hello.
Now, I don't know, physicians are very much guideline guided, let's just say. There isn't really a lot of incentive to do something new or different from what everybody else is doing because everything else follows a specific guideline that this society or that society put together. In other words, I don't think of medicine as a place where individual physicians are allowed to be particularly innovative. Often organizations are innovative, like universities and pharmaceutical companies, but not necessarily physicians. So, how did you decide or get to the point where you try to develop something new?
That started in approximately 2013, within the chronic pain domain, that is, when I was referred a patient who had terrible phantom limb pain, and the surgeon had no idea what to do and asked if I could be involved. He was specifically interested in getting my input related to skills I had in regional anesthesia. An anesthesiologist as a baseline qualification, but I've published quite extensively within regional anesthesia, which ironically comes back to the same issue of what we might call innovation, but I'll come back to this. I've got a different way of describing that process. So to come back to the amputee, I'd noticed for many years that I could completely control phantom limb pain temporarily using a peripheral nerve block. That was regarded as controversial by my colleagues. It was not regarded as controversial by the nursing staff looking after the patients because they saw this happen. Why the difference? My colleagues never came along to see, which says something else, of course. The question that then was in my mind, if I can get them pain-free temporarily, and it's really important, pain-free. Pain-free is not some relief. Pain-free is literally no pain. And the question was, how do I make this last forever?
Mm-hmm.
Can I make this last forever? And that would be a guiding principle right through this work. And it's a question of curiosity, really. If I have pain-free, then surely I have found where this comes from.
Mm-hmm.
And if I can make it last forever, then haven't I found something really quite important? Finding something important has no relevance other than what it does for the patient being at the very center of this story. And I think that it's really important to underline that the patient is actually at the center. Why pain-free? Why would I focus on that? Well, part of my reasoning there was that we need a decent endpoint. If we're going to be doing something to somebody, we need to have a decent outcome endpoint that's meaningful. And I would suggest that 50% pain relief, which is the currently accepted standard in chronic pain for interventions, is hopeless. Now that, using the word hopeless, of course, puts me somewhat in the firing line, but The reality is that if I said that 50% of the patients under my care were not asleep when I thought they were, or that 50% of the spinals weren't working, or whatever, 50% of my intravenous cannulae weren't in the vein, there would be an outcry. And yet we quite calmly say, well, it's all very well to come along and have an injection and you'll get 50% relief. Isn't that wonderful? In my experience, it's not wonderful. It's actually 50%. And then they say within the field of neuromodulation, 50% get 50% relief and the rest get less. So we're kind of degrading the standard. So I came back and said, how do we copy cardiology and oncology, who did something really interesting years ago when they made the 1 year, 5 year, and 10-year survival, and their endpoint was death. And very few people argue over whether somebody is dead or not. Now, that sounds horrible, but it did mean that cardiology and oncology sped ahead, and their research was wonderful. And the original placebo paper by Beecher from Boston is very worrying to read now. I got into reading old references through a friend who'd done his PhD in history of science through Princeton. And he said, you need to read the original references, forget the current literature, because it may be based on fallacies and mistakes and errors in the original literature. And it's amazing how often the original work has not been read properly, or there was a mistake in the original work. So I've been reading back and back and back. So we have this issue over, do we have a solid foundation in science before we start doing things? So part of that is if we're running on 50% pain relief and placebo leaps into view when you're going for 50%, are we comparing a placebo treatment to a placebo treatment? And I'm not brave enough to say, oh, no, that's ridiculous. I actually think there's a very serious issue there. Leaping away from that back to the amputee, I tried every single thing that was within the accepted domain as you talk about guideline-based practice. So she had an infusion of calcitonin, and she had a trial of epidurally placed electrodes with neuromodulation. And that was an interesting experience for other reasons. One is I managed to get her other leg tingling.
Oh.
I could not get the amputated side tingling at all. But I had the company representative strongly encouraging me to keep going, keep trying. You're nearly there. You're nearly there. Now, I've got an electrode array in the epidural space, and I'm a very experienced anesthesiologist. I'm only too well aware of the risks of the epidural space. And I actually pulled the electrode array out and said, no, I can't do this. It's not going to work. Now, a less experienced person might have said, oh, gosh, yes, let's keep on going. And then we might have ended up with a disaster in there and no effect. So I moved from there thinking, what on earth am I going to do with this person who is still crippled with pain? And thought, if my nerve block's been so effective, why don't I put the leads in her stump? Just try it. And I had a very honest chat with her about this. And she said, look, if you think it might work, let's try it. Even if I get 10% relief, I'll be happy. And so I put the leads in her stump as a trial, being very conservative, and I'm not being silly about it. And that becomes funny, having done a trial, because she was pain-free the next morning.
Wow.
But she was not only pain-free, something else had happened. Her amputated foot in her pain state was turned around and split in half. So it was pointing backwards and split in half. And with the onset of this effect, at that stage, I didn't know what it was. Her foot turned around, fused, and then disappeared. And we turn it off and it'd do exactly. So we could replicate this effect time again. So she ended up pain-free off medication. And her functional outcome score depends upon whether you have an agenda in this game or not, because if there's an agenda for oswestry disability indices, etc., you don't like what I'm going to say. But her outcome was that she is a triple world champion, double world record holder in her Paralympic event. So that's an extreme outcome for somebody who could not actually get out of bed because she was so sore. Now, was this a major fluke? Huge placebo effect, and I'm just a snake oil merchant? Yes, it's possible. Statistically, we would say that, but I also think there's a responsibility here to say, what on earth happened there? How does that work? The effect's been replicated, but it's gone a lot further than that. I then thought, well, if I can do this here, this is supposed to be impossible. If we follow the work of Herta Flor and her work on the alterations in the sensory homunculus, then what I was doing is impossible. It doesn't work. Now, there's an interesting error in her work, because when she did the original work, she'd done what's called an axillary brachial plexus block. It was an upper extremity amputee. And just as a pure irony, my doctoral thesis is on the brachial plexus, regional anesthesia of the brachial plexus. And she did not actually have a brachial plexus block performed. So her result, that there was residual change, the residual sensation, she didn't get complete relief. And if you block the plexus, you get complete relief of pain. So there's a scientific mistake in the methodology of her original work. So can we replicate? We've got something that's supposed to be impossible. No peripheral techniques are said to work in that context.
It's supposed to be a central issue.
Yeah, it's supposed to be central. If we come way forward, we'll have to jump all the way back, and we'll have to do this the whole way through to understand the threads of this work. Because this is a science project. It's not really a clinical study at all. It's about science. If we project way forwards, we are managing to stop something peripherally using a peripheral effect. And if we are wrong about that, then electromagnetic theory is wrong. And I think that would be a very brave call by somebody to say the Maxwell equations are incorrect. That's highly validated science. And this is where this is all founded. Did we have the answer back then? No. We simply had an observation.
Mm-hmm.
And part of what happened was I was immediately isolated as being a little strange by my colleagues. So I get somebody with an impossible result, and I'm immediately I would suggest that within the history of science, that's actually quite a common thing. Semmelweis is the wonderful example, demonstrated that hand washing made a big difference to the incidence of infection in his hospital, and they hounded him out. So this has happened multiple times. If you're close to the answer, that's what's going to happen. So this evolved from the amputee, and what else can we use this for? And then can we answer the question, how? So this is how it's evolved. And is there any other way of doing this? Kind of not really. It's in the ideal world, everything would be done A, B, C, D. But in reality, there are multiple examples of the same thing. In Australia, Kathy Freeman is known for her brilliant running at the Sydney Olympics with this wonderful running suit. And I was reading an account of how it was discovered. The actual suit was invented at 11:30 p.m. late on a Friday or weekend evening by the physicist who was playing in the laboratory and just switching panels around and came up with the solution. So this is not we did this in a totally systematic, logical way. No, I think science often moves in this, just people observing and being curious. So if we fast track a little bit forward in the development of this, the next thing was really, we were continuing to get pain-free. And I was continuing to use regional anesthesia to find the target, to identify where this came from. It gets trickier here. One of the problems in regional anesthesia is that anatomy and an anesthesiologist don't really go together. Anesthesiologists know lots of pharmacology and physiology, but tend to know relatively little anatomy. That's not being rude. Surgeons know lots of anatomy, and that's their territory, really. There are lots of mistakes made within regional anesthesia in terms of anatomy. And so I was correcting things as I went and keeping this eye on, am I getting pain free? Not, you can't invent pain free, but saying that had to be, we were trying to translate short-term pain free to long-term pain free. The next part of this was that the thing giving us pain free long-term was the neuromodulation unit. Now, the industry says a current stimulates nerves. There's a big problem because it's pulsed current. It's not direct current. The industry has assumed it's direct current, and that's an error in science. And that, a friend of mine is a physicist at the University of Adelaide, and he suggested that we do a simulation study just to demonstrate that, but also to have a look at how this might behave within the body, which is quite different to a vacuum. And first of all, we were able to demonstrate that it is indeed that the pulsed current of the device, and this isn't us making it up, they actually call it an implantable pulse generator. They freely admit that it's pulses. Mm-hmm. So how on earth did they jump to direct current? Now, this has absolutely spectacular implications.
Probably most away people with chronic pain. And I am, by the way, also a pain physician. So it sounds to me it's just happened by, in some ways, luck. You were desperate. You wanted to try something because the traditional guideline-based things just were not working for an individual patient. And you did something and it worked far beyond your expectations. And you felt there was something there and you just started to dig deeper into it. From what I'm hearing is that a lot of conversation in science and maybe in medicine is about the role of electricity. So electricity is used by spinal cord stimulators, which are basically what happens with that. I did an episode on spinal cord stimulators, but basically they put a probe around the spinal cord in the epidural space, and then they stimulate it, which they felt was with electricity. And then electricity is also felt to be involved in conduction of impulses down the nerves, sodium channels, which are probably the most important channels in conducting signals from a body part up to the brain, is conducted through sodium channels, which again I felt to be controlled by voltage. And what you're trying to say is that a lot of these effects are not because of electricity per se, but because of the electromagnetic field. An electromagnetic field is what is generated during spinal cord stimulation. And the reason it doesn't work very well is because electromagnetic field is not very strong at the level of spinal cord because cerebrospinal fluid dampens it. And perhaps it is stronger if you put the electrode closer to the nerve where there's no cerebrospinal fluid. So fundamentally, it's the importance of electromagnetic field and the way that electromagnetic field works with the nerves is it actually stops the sodium channels from transmitting the information up to the brain. So that was one angle. The other angle was just a discussion of what part of the body should you treat with chronic pain. There's a lot of ideas that actually pain is central for many conditions. And so if you just treat the nerves, it shouldn't really help patients with chronic pain you should maybe treat the spinal cord or maybe the brain, but not the nerves. And what you're telling me is that, when at least in this case, treating the nerves actually treats chronic pain. Is that about right?
Let me come to a few of the points, because there are some nuances here which are very important. The electricity used by spinal cord stimulators, I know you didn't actually say this, but that whole paradigm is, I'm afraid, wrong. Spinal cord stimulation is not, they're using the wrong words right from the get-go. Norman Shealy, who first placed an electrode on, he didn't place it in the epidural space, he placed it on the spinal cord itself. So he took CSF out of the equation, which is kind of interesting. They then assumed that the spinal cord, the epidural space, which is around, it's outside the fluid. It's a potential space between the bone of the spinal canal and the membrane, the dura that surrounds the spinal cord. This information isn't for Dr. Karmy because he knows that as well as I do. It's for all the listeners. Is it impossible to get an effect with spinal cord stimulation? I think the answer is nothing's impossible. It's just unlikely. And all the results would point to it being unlikely. And in the event that the epidural space is not the safest part of the body to be in, we should be careful about actually ever placing an electrode array in the epidural space. Now, given that probably 98% of the world's use of these devices is in the epidural space, you'll see that there's a real issue there. No, what we've gone and done, we're not closer to the nerve. We are more like a cell phone tower transmitting to cell phones at distance. We've just worked out how it works. Not in a, yes, we've reverse engineered it. Not completely without problems along the way, trying to work out why did we get this brilliant result. In the first 20 or so, I think we revised 50% of them because we had brilliant pain relief in some, and I couldn't understand why we didn't have brilliant pain relief in the others, having done roughly the same thing, and then worked it out. And then we simulated what we'd done, and when the electrode array is placed very close to the skin, to the dermis, you get electromagnetic scatter. And the skin, the outside of the skin acts like a parabolic reflector. So you focus the electromagnetic field towards your target. So it's just X-rays, it's the way the electromagnetic spectrum is managed. So I guess you'd have to say the technology has been completely misunderstood. And that's how we have got this remarkable result. Up to the brain, we probably misunderstand the role of the brain in all of this. Because if I put my hand on a hot plate, I'll pull it away in a reflex withdrawal long before I say ouch. So the reflex is that we have reflex patterns all over the body that occur long before we say anything. We'll turn our head towards a sound long before we say, what was that? We are sensory motor reflex beings, and we are closing off one side of that loop.
And your feeling is that maybe the brain is overrated as a source of chronic pain.
We have to change the language here to understand the papers. The scientists are unanimous. It's just the doctors who are struggling. This is, according to the science, that pain comes from activation of these sodium channels.
Let's talk a little bit about practicalities. Well, maybe let's go maybe one other direction. You started with a specific condition, which is incredibly hard to treat, and frankly, I think majority of chronic pain physicians don't have a good result with these patients,
Yeah.
and that's phantom limb pain, very difficult. So maybe first of all, staying with that diagnosis, what percent of your phantom limb patients respond to this approach?
All of them.
All of them, 100%?
Mm.
Okay.
Around that, the paradigm shift is such that the structures are not in place to look after the patients. I mean, one of them, pain-free at 3 weeks, And then, quite bizarrely, as an Australian phenomenon, this guy had to fight a bushfire to save his home and
Wow.
pulled his leads out of place. Very Australian thing to happen, but there's about it's allowing recovery. If you do not allow enough time for recovery and they don't comply, they will pull their leads out of place and you lose the effect. Just like tuning your TV or your radio or not, or having that's the way electromagnetic principles work. And so it's a vulnerability. And there have been people where we really needed to put them into a managed environment for 6 weeks to give it any chance at all. I think one of the things, the only time I haven't had any effect from leads is when the diagnosis wasn't secure to begin with. And the diagnosis being pain-free. They were not pain-free when I got a little over enthusiastic or the patient was really keen to proceed. And that was a long time ago now.
Like for phantom limb pain, do you screen them by doing blocks first?
Yes, yes. I think it's a mistake not to take them through a systematic approach. And that comes down to, are your regional anesthesia skills good enough? And does that mean I'm saying I don't miss? No. Of course I miss. Not very often. And I'm prepared to say I've missed. I need to repeat this. I need to redo it. I haven't quite got what I wanted. Can I make it up like that? No. We're talking important stuff. There's a real cost. When you are aiming for pain-free, there is an enormous cost to getting it wrong. You're potentially denying the patient a brilliant outcome.
That's phantom limb, and that's
Yeah.
honestly amazing. I've seen some patients that were able to manage better with phantom limb
Yes.
pain, but
Yep.
I've never seen pain-free with phantom limb pain. They talk about that mirror therapy, but I guess maybe it's selection bias, but vast majority of patients that I've seen, they don't respond to mirror therapy.
On that one, the selection bias, I think you'd probably agree with me. It's possible that my results reflect selection bias.
Yeah.
It is possible. It'd be an extraordinary thing if it was.
I mean, like I said, I've never seen pain-free phantom limb pain patients.
Yeah.
I've seen partial responders to ketamine infusions. I actually have done some peripheral nerve blocks for phantom limb,
Yeah.
and they got about 4 days of improved pain, not gone, but improved. But yeah, of course, people on all kinds of medications also don't work very well. So, but the broadening from there, you didn't just stay with phantom limb pain. You looked at the other conditions.
Yep.
So, what was
Yep.
your experience with other chronic pain conditions?
I've yet to strike one where I didn't get the same effect.
Mm.
Now, have I done everything? No. We're a little limited now because there's been some pushback and we no longer have any operating space. We've been denied operating space in spite of what's been published. And we've, of course, got a large database that we can refer to and we can still publish. But is this a pushback because it's felt that we're doing something bad and we've had major problems and have medico-legal consequences? No, not at all. And that would be, it's really an expected thing that would happen. But we have simply been going on based upon this, as you quite rightly say, this extraordinary result. When I had her pain-free, this first patient, it's a jaw-dropping moment. Goodness me, didn't quite. I hoped I'd get it, but didn't really expect it. Wow. And you move from there. This has to be curiosity. We all have our moments of curiosity. And now it gets very unfair because there will be people listening thinking, well, how do I get access to this? And that's one of the big deals for us. We are being stopped in our tracks and different agendas. I was talking to a statistician recently who said it's very difficult to work statistically with a binary pain score because I've been using a binary pain score for a long time now, pain-free or not. So, for example, with the recent publication, The Complete Relief of Chronic Pain, in the group who weren't pain-free, we have a confounder. The confounder is that one of those patients came back to me recently, and I was really not looking forward to the consultation because I was going to have to say to her, I can't do anything at the moment. And she said, I'm pain free. Thank you for saving my life. And that wasn't prompted. I almost fell off my chair, but she was still in the not pain free group when I counted that. And there's another one who was 98% pain free. She was at the end of her trial and she still wanted the implant and breaking the rules. But do you say to somebody who gets really very profound but not complete relief, no, I'm not going to implant you because that's not good enough for me? Or do you say, we'll try it?
So just to go down the list, there is mechanical back pain, be it from facet joints or maybe
Yeah.
even discogenic or muscle. There are ligaments, there is radiculopathy, there is fibromyalgia. So you can treat fibromyalgia with this?
Again, my practice has been whoever's walked through the door. But in those who've been referred with fibromyalgia, I've managed to demonstrate that in fact they have a series of different issues. How do I know that? They're implanted, they've got several sets of leads in. They're all medication and pain free. So it raises a question about that diagnosis.
Fibromyalgia, you're getting results. What
It,
about the other back conditions? You're getting results with them?
based on those results that were published, just over 80% of the implanted patients were pain free and off all medication. Now, if we take a slightly longer view of more recent patients, at 10 days, everybody has been pain free, which makes me way outside the guidelines. I no longer recognize the current classification,
Okay.
which won't surprise you, but I call it channelopathic pain because
That's,
that's what it is. This
that's
is a
fine.
sodium channelopathy.
Ultimately, I'm a big believer in results over theory. But what about upper body? So headache, neck, shoulder pain, radiculopathy from a
Yes,
neck disc.
works absolutely in the same principle, the
Okay.
same approach. And I think it leads into recognizing the body as being a bioelectromagnetic phenomenon.
So
And therefore, we are actually having to adapt to that science. There's an interesting issue here. Does that mean we treat everybody like this? Initially, we're physicians, we're trying to make a diagnosis as accurately as possible, and then trying to institute a treatment pathway that will be effective for that patient. And therefore, the answer has to be no, not everybody gets implanted, not everybody has opioids, not everybody has gabapentinoids, tricyclic antidepressants, etc. We have to think of who's the person. And it's one of the harder things. I thought at the beginning that everybody could be implanted, that they could all be pain free.
mhm.
It's
Well,
amazing the way people will undo your best therapy.
again, I think fundamentally there's always risk-reward ratio with any intervention.
Absolutely.
And so, if somebody can recover and is making a good improvement with physiotherapy, for instance, there's probably
Yeah,
no compelling reason to implant them with electrodes. And so, let's
totally
go
agree.
back to maybe just the actual process. So, it looks like you're using a lot of the same technology that was developed for spinal cord stimulation.
Yes,
It is
exactly the
a
same.
lot less invasive because you are not putting those electrodes in the epidural space where a lot of
Yep,
things can go wrong. You are
yep.
just tunneling under the skin into subcutaneous tissue and using almost the skin as an antenna to basically spread the
The,
signal
the
farther.
electrode, yeah, the electrode arrays the antenna. The
Uh,
skin
the
is
skin
the
is the
parabolic reflector.
okay, parabolic reflex. Okay,
Yeah.
and but then of course, so safety wise, at least to me, it sounds like it's safer than spinal cord stimulators.
Mm.
But then there's of course that inconvenient issue, and that is that you have electrodes just under the skin. So each
Mm.
time you move that part of the body, presumably you are bending the electrode. And then the other part is the actual stimulator portion, the device. Traditionally, they insert it under the skin as well. Is it basically the same process, and what is it like on day-to-day basis to actually live with it?
Very important topic. They don't complain about it. There's somewhere between a 2.5% and 5% incidence of pocket pain related to the pulse generator. And my jury is somewhat out about where it's best placed. I usually put it in the buttock. That's related to what's been done traditionally. I put them in the abdomen. It's amazing. I've seen where others put them.
Mhm.
And I'm not sure a lot of thought went into where they put them. They put them in just over the erector spinae muscles. I put them in the thigh for amputees. If you like, on a level, this is just starting. Where all these things are really good questions that I've had myself. How are we best to organize if we say, yeah, this is what we want to do? How do we best organize? For example, it takes me 20 minutes, maybe 25 minutes to make an IPG pocket. I've worked, because I have the privilege of working in anesthesiology as well, I've worked with a breast surgeon who took 10 minutes to make a pocket. So you might say, why doesn't a trained general surgeon make your pocket, or a plastic surgeon quickly make the pocket somewhere, and then you do the rest of it? Again, these are questions really for the future over how is it best organized, and how do we, the electrode arrays, people, they don't find being under the skin disconcerting. They actually find it quite reassuring, and they usually turn it up so they can feel a bit of a buzz because they say, I know it's working now. So the danger, of course, and I'm not sure if you can see me moving my hand, but skin moves. So you make a very good point about if we were designing a place anatomically to place the electrode array, it's a pretty dumb place to put it.
Mhm.
But you're not putting it there for anatomic reasons, you're putting it there for reasons of physics. The physics says that's where it should be placed. And we secure it as well as we can, and there is an incidence of migration of leads. People forget, do things, they get on with their lives. We've got lots of stories of people forgetting their problem. They just forgot they had an issue, and they pull the leads.
So I think phantom limb is a little bit easier because a lot of people with phantom limb don't use their leg very much, except for in the example you gave us.
Yeah.
But other areas, like people without amputations, for example, are there certain
Yeah.
restrictions? Are there certain things they would not be allowed to do anymore once they have the implant?
For the neck, for a cervicogenic headache where the leads go up the neck, they can't really put their chin down to their chest without, they can't do that push down. They've got to remember, I can still have atlanto-occipital movement, but I've got to be careful when I flex my neck. For low back pain, with current technology, I don't encourage people to try and touch their toes.
Okay.
I think that's just going to put pressure on there to pull them out. And with thoracic leads, thoracic have probably been, it's been an interesting exercise in working out how skin moves when we move, when the skeleton moves. I didn't know any of that. And so you raise your arms above your head and your back moves up. So how do we design? And I used to put the thoracic leads up. Now I hang them as an attempt to allow gravity to keep them down. And so this is saying we haven't quite got the technology. We now understand the science of this. And if the patient has autonomy, has self autonomy, and can make a decision that they're okay to live with a pain score of 1 or 2 or 3, should we push them to have an implant? And your point comes up. No, no, we shouldn't. We should give them the opportunity because, as you say quite rightly, every single procedure we do comes with a risk. I cannulate people for anesthesiology. I'm one of the unusual ones. I can cannulate with both hands. there's a risk of death from cannulation, from
Mhm.
infection. Never cannulate anybody if you don't need to. And I need to all the time. So I do that in a certain fashion. Your point, though, is it's a fundamental principle. First, do no harm.
So it sounds like limitations are there, but they're very minor. People can still walk, they can still run. Are they able to lift heavy things? Are they able to do most of day-to-day activities?
I think probably yes, because for a long time we didn't hear from anybody. We didn't know if that was because it had all fallen apart and they'd just gone to somebody else and saying, Dr. Cornish is a crackpot, we're not going to go back there. And then we had a steady trickle of people coming back for new batteries, and they were doing brilliantly and they were just on with life.
Okay.
And
Okay.
so you end up saying, I would probably discourage somebody from going bungee jumping,
Okay.
that crazy New Zealand activity of jumping off, maybe not parachute jumping, but as things evolve, maybe all of those things are fine if the leads will stay in place. And I don't know the answer there, but your point, they can move and we can damage nerves while we're putting things in, cutaneous nerves. So we're operating in a space of the body which is, it's all within the first 3 centimeters of the skin surface. So it's actually well away, and the risks are really infection of the unit and pocket pain and movement of the leads. And the benefit, complete relief.
Now I don't know if the leads can break as well.
I've seen one occipital lead that broke.
And then the other thing is how often, what percentage of the patients end up with leads that move, and can you then just, do you have to remove it completely then, or can you just reposition it? What happens if the leads move?
They come back saying, I'm sore, doctor, what's going on? And so I was saying to them, look, we don't get funded to put you under. If I get an x-ray, they never get quite the right projection for me to tell where they are exactly. So I would say to them, let me take you back and we will do the diagnostic injections again, but that gives us a perfect opportunity to see where the leads are. And in the public that we've published the numbers who came back, in all bar one, I was able to prove that the leads had moved,
Okay.
and they all chose to have them recited, mainly because they'd all been pain-free beforehand. And I would suggest that had they not been pain-free, because they're going to have to be limited in what they do for 8 weeks post reciting of leads, if they had 20-30% worth of pain relief, they would say, I'm not doing that again. No, take it out, it's useless. They all say, please put it back. So we put it back according to the framework, the mathematical framework, and they're pain free again. So that's happened in all but one case. And in that case, I thought there's something really quite odd here. And has he got another source of back pain? And I managed to demonstrate it. And this has gone on to be quite odd because I'm taking his unit out in a week's time. And what's happened, he's no longer sore. He's
Mhm.
pain free.
Okay.
Pain's gone. We've got a group who have been cured. Their pain has disappeared. And we implanted him, the pain went, was controlled, and then all of a sudden he noticed he wasn't sore. And he wants his unit out quite reasonably. So he had two sources of back pain, and we only really found one when we got the other completely controlled. And we've got a number of back pain patients who have got 2 units in related to two sources of low back pain, only visible when we had complete control of the other. So it's a more questions come the further into this you go.
Some of the papers that you published, they didn't quite have 100% response rates for various conditions, but that's because you were still early on and still refining the technique. Is that right?
The most accurate set of data is the latest one. It divides off into the ones where we were secure. We defined diagnosis of pain as you're pain free after injections, diagnostic blocks, you're pain free for 24 hours or longer. So less than 24 hours, that didn't meet. Now, early on, what do you do if somebody comes along and they've had to pay money, because this is not well funded in Australia. They've had to pay a good chunk of money to have some injections, come in, get anesthetized, get a whole lot of injections sometimes, and they are pain free for 20 hours. Do you say, I'm not happy with that? I'm going to repeat them. That'll be another chunk of money. And they say, you're wrong, you're full of it. So there was that pressure. And then we had the primary care physician saying, no, I'll send you to somebody much better than him. And so they go. So we have this other set of pressures. So what do you do in that circumstance? And there's a group of patients in the data set who I treated successfully, but who definitely did not meet the diagnostic criteria. But I was under pressure. One of them is a spectacular patient for another reason. She wasn't pain-free. She had about 18 hours worth of complete relief, and then it came back. And then she came to see me and said, I'm pregnant and I'm in so much pain, I'm thinking of terminating. And I implanted her under ultrasound. Pain-free, had the baby. Baby's now growing up nicely. She's delighted. Took the unit out sometime later because she was pain-free again. And if people say, oh, you're over-treating, you weren't there. And that's a really important result. So we've got now, with a trial of neuromodulation, they have to be pain-free at day 10. And we get them to turn their device off on day 7 and then turn it back on. And by day 7, they've all been all bar about one were pain-free. Again, it's if you're not getting pain-free, I would suggest you've got the diagnosis wrong. And so you've got to go, where have we gone wrong here? It comes back to history and examination. What am I missing that gave me this result? Bearing in mind that I failed to work out 5% of the back pain patients, just the published result was 5%, failed to find their source. Mm-hmm. Part of that is early days, got a lot better over time. But now part of it is also, if I told you the exact profiles of the patients, then you'd go, if you thought you could diagnose that, you're dreaming. Yeah. But we know we're trying to get pain-free. And that's where I had to have a point at which I said, no, I'm not going to try any longer. So we're going from pain-free, and it divides off into those who are pain-free at day 10 implanted, all of them say my chronic pain's gone. Over time, there are 2 or 3 who progressed beyond the 6-week period where they couldn't mobilize well. And again, on the same model that we have pain-free, and we have some people who have more than one source, are we dealing with another source? Now, my co-investigator, Anne Cornish, and we're a husband and wife team, and Annie commented that one of the patients never interacted with his unit at all. And if you're not willing to turn it up or turn it down, then this is not a textbook, you need a certain amount. Mm-hmm. And when he was very uncomfortable at the time, and he was completely pain-free when he was sitting down. And so you go, just what is the issue there? But in the early phase, yeah, all of them. So we also know from some other data, which I've yet to get published, that this is not a placebo, because that's the other question. Could I have produced this population entirely with a placebo effect, pain-free? We're replacing batteries now between 5 and 10 years old. They've all been pain-free. They all want their batteries. They're all fine. But we've got a natural experiment within that group. It's not a placebo.
So does it continue to be effective, or does it lose effectiveness over time, assuming the leads stay in place? And second of all, are some patients have a cure to the point that you can remove the unit, remove the leads, and the pain stays down?
The answer to both questions is yes, it stays, and some patients are cured. And my greatest disappointment is that it's not all of them. so that I could take the units out after a couple of years and say, that was clever. The other side of the coin is that for those who say you're over treating and these patients would have got better anyway, my answer is that if you had a therapy like this and withheld it because you said you're going to get better anyway, that's immoral and unethical. That these patients were desperate, and I took one out 2.5 years after I put it in. She was pain-free and back running around a field. When I put it in, she was on a lot of medication and couldn't get out of bed. So it's a hard-hearted person who says, no, don't do that. That's ridiculous.
Again, I think there's lots of studies that once someone develops chronic pain, chances of them
Yeah.
becoming 100% cured is vanishingly low. But I think honestly, the resistance would mostly come from the fact that you are not doing it the traditional way. Traditional way is you start with mice, then there's some kind of a startup company, university-based, that does stuff based on the mice studies, that
Yeah.
then gets approved by or gets endorsement by academic community within the university. And it's that sort of top-down approach is what I think our medical system loves.
Yes.
And anything
Yep.
that doesn't look that way, there's always a question, why didn't you start with mice? And who are you to tell us how to practice when we're supposed to be the experts in the field? That's turf war, honestly, very common. But so let's maybe talk a little bit then about access to this.
Yep.
Presume the spinal cord stimulators are not cheap. The electrodes are not cheap. Then there's codes that I mean, in Ontario, we have OHIP, which is our provincial insurer that covers procedures. It
Yep.
certainly is a code for spinal cord stimulator, but obviously there isn't a code designed for subcutaneous insertion of the leads for
Mm.
something totally different. And then you, on top of it all, you're mentioning that you might have difficulty accessing facility where you can actually insert the leads. So what are the obstacles to care here at present time?
Have to choose my words carefully here. I actually think ultimately that the public should start demanding a change in thinking. There's lots of literature describing the problem, and then this doesn't work very well, and this doesn't work very well. One of the great dilemmas, of course, is that we're the only ones who know how to do this, and there are millions affected. And this isn't a matter of me saying I'm much better than everybody else. We're physicians, we're trying to do our best for patients.
So if somebody in Australia, let's suppose, or even in Canada, wanted to access your treatment right now, what does that look like?
They can't. We're being stopped.
And that's
And
because of a lack of facility, or there's more obstacles than that.
I think this is a battle of ideology versus science.
Uh,
And the only reason I still remain in the game is I see our patients and their outcomes. I'm not silly around this. If I wasn't getting the result I say, we give up. It's become too hostile. Go away. Do something else. But ironically, I've struck this same issue in my other work. The scientist in me says, oh, that's exciting. There's a huge number of questions. Any
mhm,
decent project always generates questions. And how do we develop something like this into an available modality? I don't think really that the device itself is the key here.
mhm,
I think the understanding of pain and then the way the pathway develops from there is far more important, which feeds into what you were saying, that the patient does well having physiotherapy. You know, there are lots of patients. I've only treated, I think it's of those I diagnosed, quarter were implanted. Now, there are various reasons why the others weren't, but it still says there's a drop off. They're not operating on everybody. And there are several amputees I haven't even we've talked about implants and we've decided no together. No, it's just not worth it. So yeah, that's all. I hope that's been of interest.
That was absolutely fascinating. Thank you, Dr. Cornish. It looks like there is finally a possibility to bring the pain down to zero, which is for an interventional pain management. It wasn't something that I ever thought would happen. Thank you.
You're very welcome.
Disclaimer: when it comes to your health, always consult with your own physician or healthcare provider for personalized advice and guidance. The information provided in this podcast is for educational and informational purposes only and should not be considered medical advice or a substitute for professional medical care.